You're watching City Channel 4, your window to our community.
Kushner went to medical school at Harvard, graduated in 1985, and then he did his residency in internal medicine at University of Cleveland. He then completed a fellowship in infectious disease, also at University of Cleveland. He's board certified in internal medicine, and we had the good fortune of Dr. Kushner joining our medical staff in 2007. And I can say from my own personal experience, my name, if I didn't introduce myself, Stephen Shekel. I'm the medical director for the emergency department. And I can tell you from my experience, Dr. Kushner was a wonderful addition to our medical staff. He's been an invaluable resource since the day he came here. And I'm very appreciative of Dr. Kushner sharing his knowledge about Lyme disease. So on that, we'll welcome Dr. Kushner. Thank you.
Thank you, Steve, and thanks for everybody for coming. It's a great crowd here. I think this is a very nice event, and for those who set it up, I appreciate that. I think Lyme disease is a very interesting topic in a lot of ways. I'm an infectious disease doctor because I find it fascinating and challenging, and it affects a lot of people. I'm trained as an internist in internal medicine, and then the training in infectious disease. And Lyme disease is an illustration of what we see in a lot of infectious diseases. It was first described in 1977, but those are just the cases of people who had it. We didn't even know that it was Lyme disease then. So that's not that long ago. There may be one or two in the room who were actually alive in 1977. I had graduated from high school a year before that. And a year before that was Legionnaire's disease. So the reason I mention that is because it helps us to think about something we're still learning about. There are areas we know and we can help people with. There are a lot of areas we don't know. I'm going to try to go through the fundamental information, but I want to keep that in mind that there are more things we need to know. And at the end, I'm going to allude to a couple areas where our knowledge needs to grow. So we're going to try, for our objective, to understand the clinical features, diagnosis, and treatment of Lyme disease. Each of these areas can be kind of problematic to the physician and thus to the patient as well. And we have had some clarification in these in the last few years. Lyme disease, what is it? It's an infectious disease, as we mentioned, due to a spirochete, Borrelia burgdorferi. And this is a scanning electron micrograph of the spirochete here. This is a measure of 1 micron right here. It's about 0.2 microns across and about 20 microns long. That's a heck of a lot longer than the average bacteria. E. coli is about 2 microns long. And it's transmitted to humans by the bite of the deer tick. And Dr. Shekel was passing around some information on the ticks. The deer tick is also called the black leg tick because why call something one name when you could call it two? And here, if we look at 1 inch, all of this, so from here to here is a 1/4 inch, we see the adult ticks, the nymph and the larva. And the nymph and the larva are actually the best at transmitting the disease. And so they're quite small, and they're quite small, and so that makes some of the challenge there. And then here are a couple other ticks that we might have heard about, the Lone Star tick and the dog tick. And then finally, Lyme disease can cause a wide range of symptoms at variable times after infection. And that means a challenge for patients and for physicians because we find out it can be at many different times after a patient was exposed by the tick bite, and it can be a lot of different manifestations. So we sometimes think everything could be due to Lyme disease, or everybody we see, could they have Lyme disease? And if we are able to put it in some useful framework, that will make it a lot easier for all of us. No disease can cause everything, but physicians will remember that in the old days before we had penicillin, or even after, syphilis was like this, and syphilis shares the spirochetal etiology of Lyme disease. And in the early days of HIV, these patients came in, they had everything, and then they kept getting everything. And it made it very hard to think about with the individual patient we'd see, do you have this or that disease? So let's try to give ourselves a little bit of a framework. We'll start with that clinical manifestations, and we're going to talk about 3 main phases. Early disease, and we'll say localized, meaning localized in the body. Early disseminated, meaning spread in the body. And late disease. And each of these will have subdivisions. So early localized disease, within 1 month of the tick bite. So we acknowledge that we don't always know when the tick bite occurred. If we have a recurrent activity that puts us in contact with ticks, I like to garden. Maybe I'll remember a tick bite one time, but I could be getting them other times that I don't remember. But this is early on, 1 month of the tick bite. Rash is characteristic and occurs in 80%. We'll look at it in a moment. Erythema migrans is the name of the rash, or abbreviated EM. And let's look at a couple pictures here. So here we can see the red rounded area, and then in the center of it, a cleared area, and then another. So some people call that a target type lesion, which is one of the ways it can present. And since relatively few things present as target lesions, this makes us really think of Lyme disease. But in fact, the majority of people don't present just like this. And we'll look at a couple others. So here's one that is, again, a large one, and they're generally smooth borders, not perfectly round, but they're long, loping borders. There's a cleared area, and then the red area in the middle, erythema migrans. And then here's one on the face. On the face, I've seen a couple, and they're often quite large, as you can see there. She's cured of that, so even though it looks obviously very dramatic, and we don't wish it on anybody, but it got diagnosed and she's cured. And then here is an illustration that it doesn't have to be a bullseye appearance. It could just be a red rash. But again, kind of smooth, rounded borders in general. And so the early localized disease, besides the rash, we think of constitutional symptoms. You don't have to have all of these, but for a moment think, if I had these, I might think I had a virus. Fever, my limited hand ability. I'm not a surgeon. So fever, fatigue, malaise, lethargy, headache, stiff neck, myalgias, arthralgias, and large lymph nodes. So if I had those, or my patient had those, a virus might come to mind, and the viruses are handled eventually by the immune system. This Lyme disease, of course, we have to diagnose correctly and treat. So that's the early localized disease. Early disseminated follows this weeks to months after infection and is characterized by findings in the skin, the neurologic system, and the heart. Most commonly in the skin, and multiple erythema migrans lesions are characteristic. Let's look at these. So we have several large lesions here. Again, kind of rounded, not necessarily the bullseye or target, but we do see several of them. Several here. Now, if I saw this patient, that Lyme disease wouldn't be the first thing I'd look for. There's some atypical features. It's a little bit rounded up there. I don't know if you can appreciate that in the projection, but there's several of them around, and you can kind of think, well, it's going past where the initial tick bite was. Here, several others, and this one here with that target type lesion. And then neurologic. And so when we involve the nervous system with any infection, including this, the stakes kind of go up. We want to make sure we make the diagnosis, so we have to think real carefully, is this consistent with Lyme disease or not? We remember that we're talking about early disseminated disease, weeks or months after infection. Cranial neuropathy is a fancy way of saying a problem with one of the cranial nerves in the head and neck. By far, the most common is the seventh nerve, the motor nerve that controls the face, and we call this also Bell's palsy, a weakness. So Bell's palsy can be due to several things. Herpes group viruses can do that, other viruses, but Lyme disease is an important cause and a treatable one. If you have weakness on both sides of the face, that raises the stakes for Lyme disease quite a bit. Lymphocytic meningitis is sometimes termed viral meningitis. A meningitis, inflammation of the meninges, the covering of the brain and spinal cord, that doesn't look like a bacterial meningitis where people are very toxic, but they still have bad headache, maybe some photophobia, that is they don't like to have light in their eyes. But it looks like, it has a lot of lymphocytes, it looks like a virus. And we talked earlier how some of the early symptoms can also look like a virus. So you can see how pulling this apart in the diagnosis can be difficult. Peripheral neuropathy, meaning a problem with the nerves not in the brain or the spinal cord, but the ones going out to the body. And those going out to the body control motor or movement, and they control sensation. Lyme disease affects mainly in those that are controlling sensation. So numbness, tingling, loss of feeling in an area. So those are the neurologic findings in the early disseminated form of the disease. Cardiac issues. And I won't go into this in great detail. Fortunately, it's not common, but this is what can occur. AV nodal block, that is block of conduction from the atrium to the ventricles, which could be manifested as a very slow heart rate or an abnormal rate, not a regular heart rate. People might pick that up, and then they would see their doctor and get analyzed. Cardiomyopathy, meaning a weakening of the heart muscle. This can recover 100% once they're treated. Weakening of the heart muscle might be associated with shortness of breath or accumulation of fluid in the lungs or the legs. And finally, an inflammation of the pericardium, pericarditis, or a myocarditis. The pericarditis mainly manifesting as chest pain. But it's interesting when you think of the tropism from the kind of infectious disease viewpoint, it's doing something in the skin, which is where it started. It can do something in the central nervous system or peripheral nervous system, and then affect the heart as well. So it's very interesting and challenging. There are some other parts of these that are may occur as well in this early disseminated. Arthralgias, meaning aches of the joints, enlarged lymph nodes, inflammation of the conjunctiva, pink eye, inflammation of the liver, hepatitis, or passing of protein in the urine. Just a word for those interested, physicians will recognize this as being very similar to the secondary stage of syphilis, where we have disseminated spirochetes, and this is also disseminated spirochetes that can affect many different organs. When the puzzle fits and you recognize it, it's very satisfying and gratifying, but since it's a puzzle, it isn't always easy to put together. And then late Lyme disease, the last stage. This one is probably the most challenging, right? Because we have to think of it, we're months to years after the tick bite, and you didn't have to have the early stages. For example, you maybe never had the erythema migrans rash. But the main two areas affected here are the joints in an arthritis and the neurologic system. And I've seen several of these cases presenting late with arthritis, large joints, especially the knees. The knee has a bunch of fluid built up on it and gets very large and painful. and you can diagnose it by looking for the DNA of the organism. And then finally, neurologic, again, this peripheral neuropathy, the sensation in the arms and legs, and then a difficult to diagnose subtle encephalopathy, meaning the brain just isn't working as well. The person isn't as alert, they're not as responsive, their memory isn't as good. And because those tests are a lot more complex than some medical tests, it's harder to test brain function than to check for somebody's potassium level, right? Somebody calls me back with the potassium in 10 minutes. But to get a real test of their neurologic function, that's difficult. And to say, well, is it because they're getting older or they have other things going on like a stroke? So this can be hard to diagnose. So those are the three main clinical manifestations: early localized, early disseminated, and late disease. Let's go through making the diagnosis, and I hope this will be helpful to people maybe who have encountered Lyme disease themselves. Again, reviewing it kind of brings some unity to it and makes it somewhat easier. So we want to look at the clinical history. Do they live in an area or travel to an area endemic for Lyme disease? And this is a map of the U.S., a very nice map that's recent, 2013. And if I'm not mistaken, we're in Iowa still. And so we're in the area, right? But isn't it striking? Lyme disease was figured out in Storrs, Connecticut. And it looks like you can't walk there without bumping into somebody with it. But there's a heck of a lot of disease in the northeast part of the country. It does go down a little bit on the coast, but then the other is really the Midwest, especially Wisconsin and Minnesota. So don't go to those states. No, I'm just kidding. But that's really, I found that fascinating, very illustrative of, how different infectious diseases, probably because of the vectors, and maybe some of the spirochete himself, adapt to different environments. We do have to keep in mind, like many infectious diseases, especially those that are vector spread, when we get warmer over the years, we're warmer than we used to be, we're going to get warmer, then vectors spread. In general, they like that warmth, and so this may get more diffuse. Well, we certainly want to know about, as we mentioned before, in the history, any tick bites or risk factors for a tick bite. And then the rash with either systemic or localized symptoms that we discussed. The physical exam, we might see the rash. It may still be there, or the person will report it to us. Thank God for cell phones. They might have a cell phone picture of it. And then a localized symptom like arthritis or systemic signs such as the fever. But it really depends on the laboratory testing, and serology is the word for testing for antibodies. Here we go back to our limitations and what we know. It's very difficult to grow the organism in the lab. The average lab that's not doing research on Lyme disease can't grow it. So it's a lot different than, say, taking a urine sample, giving it to the lab, and they tell you it's E. coli bacteria, and this is what it's sensitive to. So we have to look for antibody responses where we can't get the organism. Again, one could make the analogy to HIV and such. So the diagnosis is a two-tier strategy. This, again, is similar to HIV and some other antibody-based diagnostics. You start with a very sensitive enzyme-linked immunosorbent assay, or ELISA. What they want to do is make sure they don't miss anybody. So they get everybody who's positive, but they also say positive to some who aren't. That's just the testing strategy. And then you use a specific Western blot test to narrow down that group. You don't use the Western blot in everybody, but only in the positives. And then you'll say, oh yeah, this one is a true positive, this one is a false positive. And I'll go through the practical aspects. So this first large-scale test that you test everybody with, you can be falsely positive, and what I mean by that is the test says positive, but it's really not. due to related organisms such as syphilis, which is also a spirochete, we said. Chronic infections, viral infections are the best at this, right? If you get EBV, Epstein-Barr virus, the main cause of mononucleosis, all your antibodies go through the roof. Well, if you get a test then, the ELISA for Lyme disease, it's going to be positive, okay? And then autoimmune diseases have a dysregulation of antibody production. And so these things can give you what says it's positive, but it's really not, and that's why we have to go to the second test. The Western blot is testing, does the patient's antibody, or does their antibodies react to specific proteins of the agent Borrelia burgdorferi? You can tell on the Western blot 2 types of antibodies, and so many times this will be helpful in the timing of infection. IgM antibodies are formed rapidly and then resolve or go away. And IgG antibodies, slower to form but persist for several years. So that can help us, but there are reports of occasionally the IgM lasting longer. But in the most common cases, you would form the IgM first, then you would lose it, and the IgG. So if somebody comes to me and says this all started 2 weeks ago, and their IgM is negative, their IgG is positive, then they probably got infected with Lyme in the past sometime, right? Not just 2 weeks ago, or then their IgM would be positive. But you can see this kind of complexity is a lot harder than the example of the urine, where they just told me what grew in the urine, and then I knew it. And this is a schematic of the interpretation of the test. First, we do an ELISA. That first test, if it's negative, that rules out Lyme disease. If the ELISA is positive, I have to do the Western blot, and if that's negative, you don't have Lyme disease. Physicians don't always communicate that clearly, and I've seen several people who thought they had Lyme disease because the first one was positive. I mean, everybody forgets some things, but this means no Lyme disease. If the ELISA is positive, you go to the Western blot and that's positive, then that's consistent with Lyme disease. So those are the aspects of the diagnosis. The therapy is stage specific, so we got to go back to what we heard about clinical manifestations and say, okay, early localized Lyme disease, somebody who has erythema, migraines, and maybe they have some fever. Doxycycline is the best drug, 100 milligrams BID for 21 days. And sometimes we end up treating people who are maybe diagnostically in the gray zone, not that you like to give extra antibiotics or not that doxycycline can't give some side effects, but it's still a very safe drug, and you want to be sure if you're not, or you want to try to protect the person if you're not 100% sure. The Europeans use 14 days, and their efficacy is equivalent. The U.S. is probably more conservative. I'll return to that point later. Not about being conservative, but I mean, I couldn't resist. Then amoxicillin is a good alternative. Some people, it's hard to take that, or if you're 8 years old or less. And then other alternatives, cefuroxime, and for those who have a strong allergy to penicillins and can't take doxycycline, azithromycin can be used, though the azithromycin is not quite as good. Doxycycline is the best. The second stage, early disseminated Lyme disease, a person with many different erythema, migraines, lesions, and then some systemic symptoms. If you have an isolated Bell's palsy, that's a neurologic involvement, but it's just that. Then you can use doxycycline, and the record is excellent. If you have more neurologic involvement, like meningitis or this peripheral neuropathy, it's recommended to give an IV medicine, ceftriaxone. Usually we use 14 days. I put 14 to 28, that's the national recommendation, depending on if somebody has more severe symptoms than that. So this is just remembering an isolated, the Bell's palsy, the weakness of the seventh nerve, or more involved with meningitis. And then finally, the therapy of Lyme disease that is late Lyme disease. For arthritis, doxycycline works very well. 28 days is recommended rather than the 21 we had before. If they have late neurologic disease, again, ceftriaxone IV for 14 to 28 days. In closing, I want to make a few comments about what we still don't know, and then, of course, take questions here. Just briefly, I simplified at the start, and that would have been the data up until a couple years ago, and I said Borrelia burgdorferi as the cause. Well, in the United States, that is the sole cause. In Asia, there are two cousins, Borrelia afzelii and Borrelia guarinii, cause it, not burgdorferi. And Europe, being that big gamish of countries, actually has all three. Interestingly, there are regional variations or heterogeneity in the disease. So US patients have a higher rate of systemic symptoms, multiple erythema migrans lesions, and seropositivity than European patients. European patients have less chronic encephalitis, but a greater diversity of dermatologic manifestations. So they're related diseases, but a little different. And so you can imagine making the diagnosis and how you treat, it might not be exactly equivalent studies done one place or the other. So we need to know more about this. And then one other very interesting area, recurrent Lyme disease. After you go through this whole disease, and some people have a very difficult course, you think that fate should let you off the hook and you should be immune, but we didn't make the rules. You can get recurrent disease. Does that mean we didn't treat it fully and it was hiding out somewhere? Or did you get infected again? Another way of putting it is Lyme disease eliminated by conventional therapy, or does the organism persist and have the ability to cause chronic recurrent disease? There are several studies. This is the best one from the New England Journal. They took patients who had recurrent episodes of Lyme disease after treatment of the initial episode. They had an initial episode of Lyme disease, then they had a recurrence. They had 17 patients, 22 recurrent episodes. So they either at least had 2 episodes. There were a few people who had 3 and one who had 4 episodes. They analyzed the strain of the organism from each episode, and then they looked at a protein. They amplified the DNA for the protein and sequenced it for this variable protein, one that changes between strains. In every case, all of them, the strains from paired episodes were different. So patient X, when he had it the first time, it was a different strain than the second time. The poor guy who had 4, they were always a different strain, meaning the subsequent episodes of Lyme disease were due to new infection rather than relapse with the initial infecting strain. But there's a ton we don't know about this, and this comes up with me and my patients all the time, is to say, what about the future? You'll try to protect yourself against getting Lyme disease, but they may be protected against one strain, but not against the others. And it also, as you can imagine, makes it more difficult to diagnose. I won't go into this a lot more, but it's an area we clearly need to know more about. Let me summarize with one slide, and then we'll take some questions. So Lyme disease, as we discussed, manifests as early localized, early disseminated, and late-stage disease. And each of those have some subgroupings to them. The diagnosis depends on the history, the physical, and especially the serology, both the ELISA and the Western blot. Therapy is stage-specific, that is, depending on if they're early localized, et cetera, with oral doxycycline or IV ceftriaxone. Thanks very much. Any questions? The current recommendation, I should say that a question in case some people couldn't hear. If you find a deer tick on you, before you get any symptoms, do you take some medicine? The national recommendation is no. There are calculations about how long it has to stay on. As you know, it has to be on there quite a while to efficiently transmit, and there were volunteers who did that, which is amazing. Yeah, maybe medical students or something. No, but And then, that the risk is low even when you're in an area, say, like, Iowa, Wisconsin, or Minnesota. So we don't recommend that. That's a good question. Yes. The question was, people will get treated with oral antibiotics and then given IV for a long time. Naturally, one could think of many different scenarios where one got an oral with the neurologic disease that maybe they should have got the IV and that. But I think you're referring to the more common situation where people are giving non-approved therapies. And this happens a lot in Lyme disease. It's not hard to find, including in Iowa, where people will say, I'm a Lyme disease doctor, and they'll receive months and months of doxycycline or sometimes these IVs. There's no data to support that. Now, I will say, for the patient's point of view, it's a hard illness. It's hard to make the diagnosis, and it's very, we want to get diagnosed. We want to get diagnosed with something treatable. I've seen several people who have come to me, and what they had, in fact, was dementia, which is very sad. It wasn't Lyme disease. But I think that sometimes we're not helping people if we're giving a treatment that hasn't been studied.
If we don't know enough about it, how much help are we getting from the CDC and federal government programs?
Well, to be honest, when I say we don't know enough about it, you might see me giving one of my talks on sepsis, on pneumonia. I mean, this is a common theme, and I try to point out some of our limitations. The CDC, has tremendous resources on this, and the NIH funds the studies. If you couldn't get a study of doxycycline, the company who makes it isn't going to make much money on that. So I think there is efforts to that, but it's a difficult area. But it is. I strongly disagree with people having therapies offered to patients that don't have some evidence that they're going to work. Other questions? Yes.
Is it true that insurance and Medicare won't pay for treatment of Lyme disease?
No, although I would say this way, if you're asking, Medicare does not pay for outpatient IV antibiotics. We would certainly like it to. So if one could imagine a situation where if you need IV, you couldn't get it at home, but they will certainly always pay for it, and they'll pay for the other medications. Yes?
Sir, you were reasoning about the IgM and the IgG and the diagnosis.
Yes.
So the ELISA, you say that's the broad spectrum, and we want to get some false positives in there too, so that we can make sure we touch everybody, right?
Mm-hmm.
That was unique. But the IgM.
I'm sorry, I missed that. It was unique, or?
That was unique perspective, that you smatter it broadly to scoop it. So
It's commonly done in the two-tier strategy.
So if someone has a false positive ELISA,
Yeah.
is there something else wrong with them? Something else wrong with them?
Well, it depends. They may have some reason that they've been exposed to something that gives them an antibody response. It could be something wrong, like they could have a B-cell lymphoma and produce too many antibodies. It could be something innocuous, that they've had an exposure to an antigen on a detergent or something like that causes it.
But as an infectious disease physician, you would pursue those false positives down another road, correct?
Well, it would depend. If those were depending that they could cause what the person's symptoms were.
That wasn't my really original question, that was a comment. IgMs, they go away, you say?
Yes.
Once the infection has been treated?
Even if the infection is not treated, they go away.
Really? Okay, that's interesting. And then the IgG, if someone has a positive IgM, it's very confusing, I know. If someone has a positive IgG but no positive positive IgM but no positive IgG, then it's a brand new infection. Is that what
Wait, tell me one more time your question.
Positive IgM,
Okay.
not a positive IgG.
Yes, that would be consistent with a recent infection. Exactly.
Okay.
Let me take one more question. I want to leave enough time for a second part. Yeah, go ahead.
I know there's been some stuff in the newspaper published about different cases
I don't know those cases, I'm sorry. You mean that both tests were negative and then later they were positive, or?
Yeah, within a relatively short period of time, I mean, like a year.
Oh, okay. Yes, I don't know about that, yeah. Yeah, that hasn't been reported in the medical literature, but we have to be careful about the data that's out there, you know, whether it's real data or not.
As I mentioned, I'm the medical director for the emergency department, and Dr. Barnes is my assistant medical director, and he's also the medical director for urgent care. And so that's kind of why we're going to tag team it. And our talk is about basically this: the emergency department versus urgent care. And where do I go for what? And as many of you might imagine, that's sometimes a hard question to answer. And lots of times you don't even know that until you're a little bit into the evaluation. So we're just going to simply go over a few points about this and then tell you a little bit about what Mercy Urgent Care does. So I think everybody's aware emergency departments treat what we consider emergencies. And there's kind of a general thought about that, sorry. And basically heart attacks, stroke, if somebody collapses, if somebody's having severe breathing difficulties, severe pain of almost any kind, and certainly significant trauma like in a motor vehicle accident or say a pedestrian hit by a motor vehicle or motorcycle accident. And one point I'm going to kind of make repetitively here is that for definite emergencies or severe emergencies, call 911. Just too often we see people trying to drive themselves or family members in, and we've had more than one drop-offs. We call them Bubba ambulance deliveries. When, you know, it's sort of drive by, push the person out of the car with a gunshot wound. So call the ambulance, 911. Particularly things people, I can't tell you how many times people have come in with chest pain or stroke symptoms when they're actually having a heart attack or a stroke. And so think 911 first. This is just kind of a evening picture of our emergency department. I think most of you are probably familiar with that. And as many of you, I think most of you probably know, we're open 7 days a week, 24 hours a day, every day of the year. And all sorts of medical, trauma, psychiatric conditions, pediatric adults, and the whole gamut. So, and that's one of the fascinating things about emergency medicine. You never know what's going to walk in the door, come in the ambulance bay. So, we use triage, and a lot of you are probably familiar with that, but triage is basically we sort out who's the sickest and see them first. And so if somebody looks like they're having a heart attack or stroke or collapse, we'll obviously treat them right away, and the ankle sprain sometimes will have to wait a little bit. And so the question that we're kind of addressing is, what do you do like Sunday night or early in the morning? Your child has a fever, or maybe you're having chest pain, and what should I do? That's a tough question to answer sometimes. And studies have shown that roughly about a quarter of the people who end up in an emergency department could actually very appropriately be treated at urgent cares. And the truth is, who can always know that? And so we don't certainly fault people for ending up in the emergency department who have a problem or a condition that could be treated in urgent care. And one way to address this is at Mercy on Call, and there's a lot of brochures back here regarding them. They're open from 7 a.m. to midnight, and a registered nurse is there to help you answer that question if you have a question about where should I go. Also, in the back, I have a handout, and I'm going to show this a little bit later. It's examples of symptoms appropriate for the emergency department or for urgent care, and I encourage everybody to take one of those home with them. They have numbers and some instructions on what to do. And all you can do is take your best shot, but there are resources out there to help you decide. And so now I'm going to turn it over to Dr. Barnes about urgent care, which is out at Coral West. And Dr. Barnes?
Yep. So this is a day picture, as opposed to the night picture. Somewhat represents the fact that we are open a little bit less hours compared to the emergency department, but we're only closed one day, and we're open on weekdays and weekends. We are out at Coral West, which is out in Coralville, north of the mall on 965, right behind Walgreens. And the type of things that are frequently seen there as in other urgent cares, but also we see them as well in the emergency department. Some mild conditions that people come to see us with are often flu symptoms, fevers, earaches, rashes, and we do see things such as Lyme's disease, minor sprains, minor animal bites, lacerations, things that are a little bit more moderately complex in that they require some more resources and some more expertise in terms of perhaps interpreting laboratory and also administering medications through IVs. And those are things such as abdominal pain, vomiting, diarrhea, sometimes headaches, sometimes even broken bones that are hopefully of a minor nature, but sometimes they come in with ones that are a little bit more. The expectation on most of the patients that we see there are that we evaluate their problem and then treat with a discharge home. And the duration that you're actually there is generally, because of the nature of the complaints, much less, and length of stay, LOS, is what we're referring to. But we have the same standard of care that we practice in the emergency department, which is our ECU, Emergency Care Unit. We certainly see all ages, so everything from newborns all the way to up in different years in terms of middle-aged, senior citizens, et cetera. We are open 7 days a week. We have extended evening hours. It is a walk-in service, so there's no appointments. The goal is certainly to see people in a expeditious fashion. And we do expect people to sometimes come in with things that maybe are a little bit more complicated than what we handle, and then we make appropriate dispositions with those. So if you are unable to get an appointment with your regular doctor and you don't feel that you're really sick enough to be seen in the emergency department, then that would be an area that we would be there to serve you. We do have a physician on duty at all times. We have registered nurses. Our registered nurses perform triage out there just as they do in the emergency department. So we see everyone as soon as they're there, and we make decisions if they're critically ill, such as having a heart attack or a stroke. Then those people get very quickly sent to whichever hospital in town they wish to go, and we have an ambulance that's 2 minutes away, so we can make those things happen pretty quickly. We have the ability with our triage nurses and with the support of the nursing staff to initiate these things quickly. And the other less critical cases are seen in basically an order that which you arrive, and this creates a pretty good environment for people getting seen and leaving fairly quickly with a diagnosis and treatment. So the cost is less. There's a time savings involved as opposed to coming to the emergency department. And we do have similar availability of resources, but not exactly. So certainly if you come to the emergency department, we have a very strong backup resources, respiratory therapy, and critical care people to help us. We have the availability of IV fluids, medication administration through that, as well as orally. We have an on-site lab that gives us very quick turnaround. And we also can certainly perform EKGs, administer oxygen, give nebulized treatments for people that are having problems breathing. And an AED is the external defibrillators that you see in the malls and things, and we have 2 of those as well. The good fortune of having corridor radiology right below us gives us access to all the imaging that we have here in the hospital. So plain films, CAT scans, MRIs, ultrasounds, those are all things that we can do out there just as easily, sometimes even faster, because we're not competing, if you will, with inpatient orders here in the hospital. So those can be done in a very timely fashion at urgent care. We also do sports physicals. We have occupational health, which is in the same area, and so if this is a job-related type of injury or problem, we can have very expeditious follow-up. The other things that are very pertinent, and these we follow here in the emergency department as well, is that we will work with your provider, following up a chart of what happened, what we did, and follow-up sent to them so that they know what took place at our urgent care with you, and so they can expect to follow it up based on what we found. And if you don't happen to have a primary care provider, then we can work through Mercy on Call and find one for you. And if we do need specialists to refer you to in a maybe somewhat more timely basis, such as Dr. Kuzner, we certainly call people that are specialists such as him if we're concerned about a condition that needs some close follow-up with a specialist. We also will do phone call follow-ups after you leave within a day or so to see how you're doing. And if there are further testing that you may need in addition to what we performed there, then we will assist in facilitating that as well.
Good. Thanks. And so this is just, I don't know if you can read that very well, but the idea was I really would like people to take this home with them. It's not a complete listing because, as you might imagine, it's impossible to do a complete listing, but this is just examples of symptoms appropriate for emergency department and the same for urgent care. And a lot of it's intuitive, but things like stroke symptoms, sudden weakness, severe breathing difficulties, or severe pain of any type, and other minor injuries, and they're just examples. Like we see a lot of colds and earaches, ankle sprains, those sort of things in urgent care. But the truth is we see a lot of those same complaints in the emergency department. And like I said, we're happy to treat people wherever they come, but this is to give you a little bit of a guide on where to think about first. And again, if you are having an emergency or a family member or loved one is, remember, call 911. It really is underutilized, and they can provide life-saving treatment before you get to the hospital in these time-dependent diagnoses. And the other thing is, when in doubt, just give Mercy on Call a phone call. You have a registered nurse waiting to help make that decision with you. And just in summary, the emergency care unit or our emergency department, we're ready for anything, anytime. That's part of the benefit and actually part of the fun of being there, because you feel like you can make a difference, and occasionally we do save a life, and that's a big deal. So we're there all the time, and call 911 for things, particularly time-dependent diagnoses, chest pain that might be a heart attack, or any signs or symptoms of stroke, or any other serious emergency. Paramedics, we're very well covered in this area with paramedics, and they are well trained and there to help you initially, so just call 911. And when your doctor isn't available and you feel that your medical needs are urgent but not emergent, urgent care is the place to go. And just to try to help you a bit with some of these time-dependent diagnoses, I have a number of brochures back there about heart attack and also stroke signs and symptoms. And we do give talks about stroke and heart attack here, and I encourage people to come because a lot of stroke and heart attacks are underdiagnosed, and when that happens, the end result is much worse than it could be. So take one of those home with you. Also, information about Mercy on Call. There are brochures, magnets, but also a little card where you can list your medications. It's very important to have a list of your medications when you come in for treatment. So please take those home with you. And just finally, both the Mercy Urgent Care and the Emergency Care Unit, we're doing our best to help patients in our community. And so utilize us in the best way that you feel is appropriate. It's never wrong. And if you make the wrong call, either place, you'll never be criticized for coming to the emergency department. If you end up at urgent care and you need immediate treatment, we're going to call the ambulance and get you right there and we'll call ahead at the emergency department and let them know that you're on the way. Or Mercy on Call. Please take that number home with you and use it as much as you possibly need to. So with that, any questions? Okay, well, thank you for that question. The question was, how do you find out where the ambulances are here in Johnson County? And should that, in a way, should that be a part of the decision-making process, whether you should take the car and drive in or call the ambulance? And my short answer to that, and I'll expand upon it, the shorter answer is don't drive in. Don't load that patient up and drive them in, and don't allow the patient to drive themselves in. I can't tell you, if you think about it, if somebody's having chest pain, it might be a heart attack. One of the problems with heart attack, what kills 50% of the people who die with heart attack is what we call sudden cardiac death. That's a fibrillation. A lot of you might have heard of that, ventricular fibrillation. And when that happens, the lights go out, and unless there's emergency personnel right there to defibrillate them, they're going to die. And so my answer is call 911. You can find out where your ambulances are located generally by calling Johnson County Ambulance Service. But please don't let that be a factor in whether you decide to drive yourself or have somebody drive themselves in. Back here. The question is, if somebody drops something big and heavy and painful on their foot, and then they pass out, where should you go? And as I said, these are tough questions to answer because there are a lot of things come into play. Is the person young? Is the person healthy? It's not abnormal to have what we call a vagal response, where somebody sees blood and they faint. If somebody saw blood when they were having blood drawn and they faint, urgent care would be fine. If this person's a young, healthy person, they faint after having severe pain, but then are fine. After that, urgent care is fine. And so each case is nuanced and different, and that's why I say, don't be afraid to call Mercy on Call. You could have a conversation with them, and they could give you very good advice. The question is more of a comment. The comment is, where the heck is that place, okay? Thank you for that question, comment. And perhaps Phil can address this, but basically, Phil?
Yep. You're right, and it is, if you want to go by the compass, it's north of Walgreens. But you're right, if you're going 965 towards North Liberty, you will not see it because Walgreens is on the corner, the northwest corner, and then the clinic or the building, Coral West, is behind it. And the sign, you have to go by Walgreens going north to see it. So that's kind of a question of signage. Of course, Steve and I we were not consulted in that whole decision-making process, but I think it does bring up a good point, which is that people need to be aware of any kind of building, and especially in urgent care, by very prominent signage. And so you're not the first one to comment on that, probably not the last. And so that's something that we will, again, run by some people that can do something about it, which is not us.
And in other words, we have some work to do. Thank you very much. Question? We do see plenty of ticks in the emergency department or urgent care. And we do remove ticks. And from my perspective, and I can speak for myself, I like to know whether it's a deer tick or a wood tick. And that card I passed around helps identify that. Certainly there are diseases that can be transmitted by wood ticks, the common dog tick. But if it's a deer tick, it'll just potentially make you a lot more vigilant. And so I think there is benefit in identifying the tick. And we're experts at removing ticks. So.
To see if they actually had the bacteria? There's not a lab that...
No, there is not. So with that being said, thank you very much for your attention and joining us tonight. And stay around for questions afterwards if you'd like. Thanks a lot.
You're watching City Channel 4. On TV, online, on demand, on Facebook, and now on the go on your mobile device.